There are nice small monitors that you can purchase now. They are as good as basically an overnight polysomnography is at least my personal bias. And then if you look at the AHI, there's really quite impressive improvements in this collective of patients. And maybe even most importantly, if you look at the interactions between opioids and breathing, then you can see that the ODI increases the oxygen desaturation index in patients during atmospheric pressure, but only minimal increase in patients when they were on CPAP. So CPAP is basically forgiving, so it decreases the respiratory depressant effects of opioids. Of course, if you give enough opioid, the patient even on CPAP stops breathing. So this is what I wanted to show you, maybe as the final slide. So this is also for discussion. So for next Miller textbook of anesthesia, we're going to have this algorithm. How do we treat our patients with sleep apnea? We don't know. Just at Mass General, we just met with pulmonary critical care people, with respiratory therapists. And our answer to that is patients should be asked, did you ever get a sleep trial in your life? And if yes, then we want to know, is there a high-risk procedure, yes or no? If there is a high-risk procedure, then we want to know if the patient has really sleep apnea. If the patient never had a sleep trial and has a low-risk procedure, such as hardware removal at the ankle, then we just don't care. We do care, but we do not request a sleep study and do not apply additional strategies such as CPAP perioperatively. But the ones who have a high-risk procedure, like a AAA, open AAA, they really would say, okay, now we want to know if you have sleep apnea, we consider perioperative CPAP. And also in the patients who did have a sleep study, then we want to make at least sure that those who have CPAP prescription at home use it perioperatively. So we match them with the respiratory therapist and make sure that they get the CPAP. So finally, body position. Shiro Isono has shown many years ago in different experiments that body position matters in terms of airway stability. And I just wanted to show you this data. It's also preliminary. In the OB floor, I've mentioned it before, we measure acoustical pharyngometry during wakefulness, see that body position, the elevated body position increases airway size, and the increase in airway size during wakefulness translates to a more stable airway patency during sleep. So maybe we're going to do a follow-up trial, and maybe we should have patients who are vulnerable really not be in a supine position, as been mentioned before by you, but we should make sure that patients with high vulnerability collapse in the perioperative phase are sitting or up, or at least in this study we did the 45 degrees increase in body in the back position. So it did not translate to impaired sleep quality, at least in this trial. So I'm wrapping up and saying anesthesia and sleep increase the vulnerability to respiratory failure. Some anesthetics have less intense effects than others. Consider respiratory stimulating effects, and I don't know if carbon dioxide, which we did in this volunteer trial, has really a future in perioperative medicine. We will see. CPAP improves breathing and ameliorates the respiratory depressant effects of opioids, and precision matters. Don't have your patients assume the supine position when they are at risk of respiratory failure and airway collapse. Thank you very much.
Questions? Yes. That was a great talk, Matthias. I had a question about your trial with CO2. Mm-hmm. So I assume the reason you had it in box plot is because there was some spread of data, right?
Yeah.
So within that spread, did anybody get worse?
In terms of peak close?
Yeah.
I don't know. I cannot answer that. So, but the trend is clear. Yeah? That there is an increase in ventilatory drive, an increase in genioglossos. So, I mean, I think the real clinically important question is, can we do that in patients in perioperative medicine? What is the pH? Do we have, I mean, to begin with, what if you have opioids and sedatives, and you, on top of that, give them carbon dioxide? Is it still safe? Basically increase, paradoxically, just because you suck harder but I don't think that we observed that in the 11 volunteers that we studied in this proof of concept trial.
Other questions?
Yes. I had a nice study with the propofol and CO2. What were the effect site concentrations in the low and the high? Remember?
The effect size.
The target effect site concentrations that you went for on the low and the high groups.
So the low dose was basically very close to the ED50 reported values, and the high dose was 50% higher. So we, of course, we would like to do up and down real titration, but it's very challenging. The only thing that we can say that the low dose was a dose that just did not abolish a response to a pain stimulus. So we gave a transcutaneous 50 milliamp tetanic stimulus. And the low dose did not abolish the response to that stimulus. The high dose did abolish the response to that stimulus. So in 2-3 preliminary experiments, we figured that we really need to increase the dose quite substantially. So we increased it about 50%. So the 50% difference and the behavioral correlates, indicating that the doses were different from a biological point of view.
Did you have an EEG measure on during that?
Oh yeah, yeah.
And
So you want to know the BIS?
Yeah.
So BIS high dose maybe 30, and low dose maybe 50, 60.
Another question about, so the effects of propofol that you showed on the junior glosses, I'm trying to understand, for example, when ENT surgeons use drug-induced sleep endoscopy as a surrogate to make decisions about upper airway surgery. So do you think that mimics sleep, or the impact of junior glosses is exaggerated with propofol compared to natural sleep? Therefore, what would be the role of DICE?
So there are certainly the similarities between normal sleep and propofol-induced anesthesia. So this is not propofol-induced sleep. I'm a believer in the concept of propofol-induced sleep. Keyword Michael Jackson. That's not anesthesia. So this is anesthesia. They did not respond to pain stimuli. But regardless, so in terms of genioglossus, it looked similar. So I learned in Atul's lab that during wakefulness, many times you don't see genioglossus activity. But when they fall asleep, then you see robust, nice genioglossus activity. And we saw the same thing during propofol anesthesia. But then, particularly the tonic activity went nicely down from wakefulness to low dose to high dose. Phasic was a little bit more complex. But the phasic, interestingly, responded very nicely to carbon dioxide stimulation.
Okay. Thank you very much. Well, I would just like to say thank you all for coming, and I would also like to thank the organizers for inviting me, especially to visit San Francisco at a time of year when the weather here is almost as nice as the weather we routinely have in Seattle. So it's, again, my pleasure to be here. We're going to change tact and focus a little bit now, and I'm going to present a very brief overview and the limitations of time that we have to discuss and share with you something that we already know, but that I believe is an understudied area, and one that, at least in my own bias, constitutes low-hanging fruit, as we discussed briefly in the discussion before our session actually started. So most of the information that we have about the relationships between sleep and immune function, and certainly the early studies, were really derived from studies that focused on what happened to sleep, what is the impact of infectious processes on sleep in terms of magnitude and duration, how is sleep altered, and the fundamental question that still, I think, remains somewhat to be answered is whether the changes that occur through the course of an infectious challenge in the way we sleep actually facilitate recovery. I mean, this is what we would like to believe. This is what our mothers have told us. We would like to think that the way we sleep when we are sick facilitates recovery. From the period of the mid-1980s until now, many different models, some preclinical animal studies, some human observational studies have demonstrated the impact to which a variety of infectious agents alter sleep. And I've listed for you on this slide at least every type of pathogen that has been studied to my knowledge with respect to sleep. And you can see that by now the list is becoming pretty impressive. And if you think about the human condition and you look at some of the infections that have been studied with sleep, you'll see that at least for some of these pathogens, it's very likely that you could end up in the hospital and perhaps in the ICU. There are other reasons to end up in the hospital or the ICU that are a little more traumatic in some ways. We know that through the course of neurodegenerative diseases, sleep is altered, and I've listed some of these for you here. And obviously, if the brain is subjected to an insult of suddenness, such as traumatic brain injury, you can also end up in the clinical setting when you would probably prefer not to be there. Now, with respect to the types of insults that the brain can occur, epilepsy, stroke, and traumatic brain injury, there's very much an inflammatory component to these pathologies as there is in our neurodegenerative diseases, which in some ways are similar to the inflammatory responses that occur through the course of an infectious challenge. So one of the fundamental common threads through the course of ending up in the hospital seems, at least for many pathologies, to be inflammation. So if you end up in the hospital or in the ICU, there are many different factors that can contribute to immune suppression or alterations in immune function. Obviously, you can be anxious about the procedures that are going to occur. There's a large literature of the effects of stress on immune function. There is quite a substantial literature on the choice of the anesthetic per se and the effects of anesthetics per se on immune function as there is for the surgical manipulations per se. The very act of cutting with a knife is immunosuppressive. Many medications that individuals on alter immune function, and the underlying disease can have an impact on immune function as well. But for today, for a variety of reasons, including the audience that's here, I thought I would focus on the sleep disruptions that occur in the clinical setting. And what I would like to do for the rest of my allotted time is to review a few of the studies that demonstrate the extent to which sleep is altered in the clinical setting. As practitioners, this will be no news to you. You are already well aware of the many factors that can disrupt sleep in the clinical setting. And then I would like to finish by demonstrating that we do know some of the mechanisms by which altered immunomodulators and immune active substances affect to regulate or exert their effects on sleep and provide a mechanistic basis for interactions between sleep and immune function within the context of a clinical or an ICU setting. So it turns out that there are quite a few papers being written on the extent to which sleep is altered in the ICU or the clinical setting. And generally these papers focus more on the disruptions that occur and much less on the impact of those disruptions or reporting efforts to change those disruptive factors. So as I mentioned, there's a relatively large literature. These are two representative reviews. Dr. Mays has published, and we'll hear more from him next, on interactions and common pathways perhaps between sedative hypnotic agents and sleep. Dr. Leidig will speak to us this evening about the same topic in greater detail. So we know that sleep is disrupted in the ICU, and I just want to show you what I consider to be a few representative studies to demonstrate and provide quantitative evidence for what you already know. The first of these I consider to be a relatively classic study from Crackman that was published in the mid-90s. And what was demonstrated in this study is that the attempts to help people recover were actually very disruptive to their sleep. So this phrase, I think, is very insightful. Due to intensive individualized care and monitoring, these patients often suffer from severe sleep deprivation. And he goes on to demonstrate some of the factors that occur in the ICU setting that are disruptive to sleep. And in the review that he provided, at that time, he presented results from some papers that had already been published, and some of these you're already familiar with. The classic study by Orr and Stahl on thoracic surgery patients demonstrated that there was essentially no slow wave sleep in these patients and no REM sleep. So although the studies to this time demonstrated that there were varying amounts of total sleep that patients could get in the ICU setting. Certainly with respect to the deeper stages of sleep or REM sleep, it was essentially non-existent. A study that was published a few years later, this study was published out of the group of Penn. Neil Friedman was the first author. They really focused on the impact of environmental noise in the ICU setting. One or two of the things that really intrigued me about this study was that they demonstrated that in the ICU, the mean maximum and the mean peak environmental noise exceeded EPA recommendations. So had this been, let's say, a factory rather than an ICU, they could have been cited for being non-compliant with recommendations of EPA for workplace safety. So here's a figure from this paper that demonstrates an arousal that occurs in a sleeping patient with a burst of noise that was measured at 69 decibels. Do you know how loud 69 decibels is, dBA? It's a little louder than a lawnmower. I didn't really know, so I did the next best thing. I went to Google. 69 dBA is equivalent to a train or traffic on a busy street. So you can imagine a patient in the ICU trying to recover from whatever with the train essentially going through the room at night. So it's no surprise that sleep is disrupted. What I think is the most interesting figure in this paper is this one. This is simply a very crude schematic representation of sleep-wake behavior of 5 subjects in the ICU setting in this study. Here you can see sleep is indicated by the black bars, wake by the white bars. I am not boarded in sleep medicine. I am not a neurologist. I'm not a sleep doctor. But I don't have to be to tell that there's a real problem with sleep in these subjects in this study in the ICU. Now, I would like to ask you to indulge me and keep this sleep pattern in mind for this particular subject, because we will mimic that in an animal model. You're all familiar, of course, with the expression to sleep like a baby, but if you happen to be in a pediatric ICU, you don't sleep like a baby, at least not like a normal, healthy baby. This was an observational study based on 9 subjects in a pediatric ICU, and the results, again, were fairly striking. On average, these subjects received less than 5 hours of sleep a night. They were interrupted essentially every half hour. The average noise level in this study in the ICU was 55 decibels, which isn't that much different than the burst of noise I just showed you. There were sudden and sharp elevations up to 90 decibels in the ICU in this study. And noise, light, contact with caregivers were the significant predictors of the amount of sleep. So it's not hard to understand with these environmental factors, which you would not tolerate in your own bedroom, that it's hard for patients to obtain anything like restorative sleep in the ICU setting, irrespective of whatever else may be occurring. Okay, so sleep in the ICU is very disrupted if it exists at all. There are many other studies that demonstrate the extent and the facets of immune function that are altered in the ICU. These include items that I've listed for you on this slide. Most of these changes in immune function are acute changes that we refer to as occurring in the innate immune system, and they all involve the effects of a class of molecules which we refer to as cytokines. Now, within the context of immunology, cytokines are very important. They play many different roles within the immune system, but you can think of them as messengers, and they convey information between and among the various cell types that comprise the peripheral immune system. Now, for many years, the dogma was that the brain was an immune privilege site, and that if you detected cytokines in samples obtained from brain, you must have contaminated your sample during the collection of those brain tissues. For many years, it was impossible, or I should say very difficult, to convince individuals in the field that cytokines and their receptors indeed are expressed in normal healthy brain and function in normal physiology in the absence of pathology. Now I'm happy to say this, the idea that cytokines and their receptors are found in brain is well accepted. This is just one image I'm showing you to demonstrate that fact. You might not be able to see the fluorescence very well given the lighting in this room, but if you focus on the left-hand panel, this is an image obtained by Ashley Ngiosi, a graduate student in my lab. And if you can see the green staining, this is normal tissue from a mouse, and the green staining is indicative of an interleukin-1 receptor. So we and others now have amply demonstrated that cytokines are in brain. The machinery for their functions is in brain. And once it became apparent that they existed in normal healthy brain, many different labs and investigators began to determine what they were doing there. And we now know, on the basis of many different types of studies, that cytokines play a critical role in the regulation or modulation of many physiologic and behavioral responses in the absence of pathology. And I've listed the ones that are of particular interest to us on this slide. Now, if you look at this list and you think about how you feel when you are sick, you know that you're not interested in social interactions. You may very well lose your appetite. Your mood can be altered. You often simply desire to crawl off and go to sleep. It's not much of a stretch to think that cytokines playing a role in normal physiologic processes would also function in brain to modulate behavior during the course of an infectious challenge. But up until about the late 90s, we didn't really know where or how in brain cytokines exerted their effects with respect to sleep. Even though many cytokines and growth factors have been studied with a role for sleep, most of what we know has been derived from studies of interleukin-1, interleukin-6, and tumor necrosis factor alpha. So these three cytokines we often refer to as the big three, and they have been studied extensively with respect to sleep and their actions in brain. Now, I don't have time to review 25 years worth of literature that demonstrates a role for these cytokines in the regulation of normal physiologic sleep, but I will spend a few minutes showing you data that demonstrates where and how they act in brain, at least within the context of sleep. So first of all, if we have physical systems in the brain that seem to play a role or were identified as playing a role in the peripheral immune system, that we would hope to see, if there's a link between sleep and immune function, that they would change through the course of either natural sleep or sleep deprivation. And I could show you a lot of data, but I've simply provided a few slides that demonstrate what I think are some interesting features. So first of all, we might expect to believe that if your sleep is disrupted for prolonged periods of time, for weeks or months or more, that would have a negative consequence on immune function. But what we might not realize is that it takes only a very short period of disruption to sleep to induce an inflammatory response. And that's what I'm showing you in this study that was published a few years ago by Michael Irwin and Steve Cole at UCLA. In this study, they brought 30 healthy subjects into the sleep lab. They did full PSGs. They had 3 nights of baseline sleep recordings during which they were taking blood samples. Then after these 3 baseline nights, they restricted sleep of these subjects to 4 hours. So instead of having 8 hours time in bed or opportunity for sleep, they had 4 hours, and again, they were taking blood samples. So now we're talking about a protocol in which sleep was simply reduced, or sleep opportunity was reduced from 8 hours a night to 4 hours a night. They took these blood samples, they subjected them to fact sorting, and presented data like this, which I will take a moment to explain to you. So this is a study in which leukocytes, in this case expressing CD14, which is a surface marker for a particular cell type in the immune system, and they gave them an immune challenge ex vivo. So this is the blood sample. They incubated it with lipopolysaccharide, which is a very strong immune adjuvant to induce an immune response. So in a blood sample taken from one of these subjects after a full night's sleep, so during the baseline recordings, this is the profile that they got in this flow cytometry study. So of these CD14 positive cells stimulated with lipopolysaccharide after a full night's sleep, about 6% of these cells expressed markers for IL-6, and about 5 or 6% of these cells express markers for TNF and IL-6. Full night's sleep, roughly 5 or 6% of the cells are positive for IL-6 or IL-6 and TNF. Same subject, blood sample obtained after 4 hours of sleep restriction shows quite a different picture. Now, upon stimulation with LPS, almost 25 or 26% of these CD14 positive cells expressed IL-6 or the combination of IL-6 and TNF. So this is indicative of an inflammatory response. Further analysis that was presented in this paper demonstrated that these effects were due to activation of the NF-kappa B transcriptional pathway. But the point I would like you to remember is that reducing sleep opportunity by only 4 hours for only one night is sufficient to induce a classic inflammatory response in otherwise healthy subjects. So we have recently begun in my laboratory to focus on not the effects of total sleep deprivation, but the effects of sleep disruption or sleep fragmentation of laboratory rodents on various aspects of immune and brain function. So Pauline Barf is a postdoctoral fellow in the lab. She comes to my lab from the University of Groningen in the Netherlands. And we have recently just evaluated and published our, validated and published our first paper on a device that allows us to mechanically disrupt sleep of laboratory rodents for prolonged periods of time. Briefly, this device The floor of this device is a turntable. I think most of us in the room are old enough to remember record players. That's essentially what we have. We have a turntable. There's a divider wall such that 2 mice can be housed on this device simultaneously. This device is programmed, a computer program controls this device, and we have a protocol in which this disc rotates once on average for 8 seconds during each 30-second interval throughout the period of interest for us. So a couple of things that we had to do, because mice are a little more clever than you might anticipate. In order to minimize their behavioral adaptation to this device, we randomized the direction of the disc rotation, and we also randomized the interval period of disc rotation. So they never know exactly when it's going to rotate, and they don't know which direction it will rotate. And as a consequence, every time the floor moves, they wake up. Now we rotate the disc floor more than 180 degrees, so if they happen to be on one side and the disc happens to turn in that direction, they could ride all the way around. Eventually, they will bump into the divider wall and wake up. This was our thought. In actuality, it doesn't take very long before the mice learn to go to the center pivot point or get as close to the center pivot point as possible, and as a consequence, when the disc rotates, they hardly move at all. But because we wired these animals for EEG recordings, we know that they still wake up, and that's what's depicted in these 2 hypnograms. So here's a hypnogram for a 1-hour time period of a mouse on this device with no disc rotation. And you can see that we have consolidated periods of waking and periods of non-REM sleep and REM sleep, and these cycles are normal for a mouse. When the disc is rotating, the picture is quite different. You can see the extent to which sleep is fragmented. When they're awake, of course, they're awake, but when they're in non-REM sleep and the disc rotates, they wake up. So a couple of things I should tell you before I show you some data, because I don't have time to show you all the data. After the first day, and for our initial protocol, we fragmented sleep of mice only during the 12-hour light period. We maintain our animals on a 12-hour light-dark period. Mice sleep more during the light period than they do during the dark period. So by fragmenting or turning this disc on and off during the light period, we are fragmenting most of their sleep. These animals were allowed to freely behave during the dark period, so they could sleep if they wished or not. So after the first day on the device, when they lose a little bit of non-REM sleep, about 10%, after that first day, the amount of non-REM sleep that they obtain through the 12-hour light period does not differ from control periods when they're on the device, but it's not being rotated. So this fragments their sleep, but it doesn't reduce the overall amount. Now, REM sleep, on the other hand, is completely eliminated from the repertoire because there are this 30-second interval is not enough time for them to enter REM sleep, for the mice to enter REM sleep, because before they have that chance, the disc will turn and they'll wake up. So REM sleep is completely abolished. Non-REM sleep is not reduced in amount, but it is fragmented. Now, this is very, very similar to what is reported to occur when individuals are in the ICU. And you remember the fragmented pattern that I showed you from one of the subjects in the Friedman study. REM sleep essentially does not occur. Whatever other sleep occurs is very fragmented. We were surprised in our initial validation study that even though REM sleep is completely abolished and even though non-REM sleep is disrupted in this manner, during the subsequent dark periods, when the animals are allowed to freely behave, there is no rebound in either sleep state. That was unanticipated, and the protocol that we validated and is published, we continued this protocol for 9 days, and even at the end of 9 days, there was still no rebound in non-REM or REM sleep during periods when the disc was not rotating. That's an interesting story, and I've spent some time on it, but it's not really what we're here to talk about. After a very short period of time of having sleep fragmented on this device, the amount of TNF protein that we quantified in the hypothalamus or in the hippocampus is increased by about 40%. So simply by disrupting sleep of mice for, in this case, a 3-day period, allowing them to sleep normally during the lights off time, tumor necrosis factor, which is one of our inflammatory cytokines in the hypothalamus and hippocampus, increases by about 40%. When we look at other markers of inflammation in the brain, which is whether or not glia are activated, we get another interesting story. We seem to have an effect of this device on astrocytes. GFAP is a marker of astrocyte activation, and in this case we focused on the arcuate nucleus of the hypothalamus. Here what you're looking for is the bright green staining, which you see when the device is turning and sleep is disturbed, but not in animals that served as device controls before sacrifice. So in terms of increases in an inflammatory cytokine at the protein level and increases in markers of activation of astrocytes, being subjected to this sleep fragmentation protocol for as little as 3 days is enough to induce inflammation in the hypothalamus. And this is simply the quantification of the astrocyte data I just showed you. Numbers of astrocytes expressing this marker of inflammation increased by about 20%. So what does that mean, and why do we care in terms of sleep-wake behavior? And what I'd like to finish with now are just a few results of a few studies to demonstrate that we think we have at least some ideas of where and how in brain cytokines exert their effects on sleep. So first of all, we know that if we administer to laboratory animals, or in some cases human volunteers, cytokines, the amount of sleep and their patterning of sleep is altered. This is results from one such study in which we administered interleukin-1 intracerebral ventricularly into rats. We focused on 3 different rat strains, but what I would like you to focus on today is that after IL-1 is administered into these rats, there are periods during which slow wave sleep is essentially doubled, as depicted in the closed circles, relative to control recordings obtained from the same animals, which is depicted in the open circles. So slow wave or non-REM sleep increases, REM sleep is suppressed when we give IL-1 to laboratory animals. Well, in conjunction with a close friend and collaborator at the University of Milan, we began to try to focus on regions of brain that would exert these effects. I won't take you through all the data, but suffice it to say the preoptic area in the basal forebrain and the brain stem play a role in mediating IL-1 effects on non-REM sleep and REM sleep respectively. So we know this because of a series of studies, the first of which we did in collaboration with Dennis McGinty and Ron Smuziak at UCLA. They have a very powerful tool at their disposal, which is to use microdialysis approaches to perfuse substances into brain. So rather than using microdialysis to collect extracellular fluid from the brain, they reverse the pump and use that system to administer very slowly substances of interest into brain. Now, what was of interest to us was the fact that they have microwire bundles around the microdialysis probe so they can record neural activity or discharge rates from neurons that are immediately adjacent to that probe. So what we did in collaboration with them was to focus on the preoptic area where they already knew there were 2 classes of neurons, wake-related neurons, so-called, because when the transition from wakefulness to non-REM sleep occurs, discharge rates were reduced. So wake-related neurons fire at a greater rate when the animal is awake. Conversely, sleep-related neurons fire at greater rates when the animal is asleep. Now, we initially hypothesized that IL-1 would exert its effects on sleep by acting on sleep-related neurons or sleep-active neurons. It seemed logical to us. But we were surprised to learn on the results of these studies that that's not at all the case. Administration of IL-1 into the preoptic area actually reduces the discharge rate of wake-related neurons by about 50%. So this was the first evidence that we had that IL-1 exerts its effects on arousal or wake-promoting systems rather than sleep-promoting systems. Another study that demonstrates this in a slice electrophysiology preparation, when IL-1 is present in the bath perfusate, presumptive serotonergic neurons in the dorsal raphe nucleus reduce their discharge rates. Another arousal promoting system. If we focus on REM sleep and IL-1 is microinjected into the cholinergic brainstem, an area that Dr. Leidig knows really a lot about, if we microinject IL-1 into the lateral dorsal tegmental nucleus, the amount of REM sleep is reduced by about half, no effect on non-REM sleep, and if we miss the target, there's no effect on either REM sleep or non-REM sleep. Once again, in the slice preparation, this time targeting chemically identified cholinergic neurons, when IL-1 is present in the bath perfusate, the discharge rate of these cholinergic neurons in the LDT is reduced by about 50%. So now we are fairly confident in saying, and we have other data that I haven't shown you, that at least for IL-1, the primary mechanism by which it exerts its effects on sleep are by suppressing activity of wake-related or wake-promoting systems. So with that, I'd like to summarize what we've talked about briefly. The take-home message is that we know that sleep disruption is immunosuppressive and induces inflammation both in the periphery and the brain. If sleep disruption is bad for us within the context of health, then it seems that trying to improve the quality of sleep in the clinical setting or in the ICU would be some low-hanging fruit that is ripe for investigation. When you consider all the factors in the clinical setting that cannot be changed, ranging from the types of surgical procedures that need to be conducted, the underlying illness that the patient presents with, it seems that environmental factors would be something relatively easy on which to focus with the idea of improving the quality of sleep of patients in the clinical setting and as a consequence, perhaps contributing to recovery. And with that, I will thank those in the lab who actually do all the work and entertain a few questions. Yes, Ralph.
Thank you, Mark. Congratulations. A number of us are interested in another side of town. I know Gershon is, Bergen is, and these are leptin. What about the idea that leptin alters immune function? Do you have anything about that?
The question is whether or not leptin alters immune function. There's a growing literature, none of it is ours. But I can say that one of the reasons we developed the sleep disruption device is to focus on the relationship between disrupted sleep and metabolic syndrome / obesity. And that's what Pauline Barth is working on as well. So I can tell you that we have samples that are being collected, and as part of our neuroendocrine assays, we will be looking at leptin, ghrelin, insulin, glucagon within this protocol of chronic sleep disruption.
So your the mouse model that you showed in terms of sleep fragmentation, you said you're doing it during your normal sleep.
Correct.
So what happens during the day? I mean during the night?
So during their night, we anticipated that they would have a sleep rebound, but this is not the case. They behave absolutely normally. So you have to think a little bit reverse from us because most of the sleep a mouse gets is during the light period and most of their activity is during the dark period.
Yeah, I mean, to some extent, it's like shift worker.
Exactly.
You're creating a shift worker model, although, I mean, so there's some circadian misalignment probably as well going on here,
Yeah.
in addition to just some sleep fragmentation.
So what is very interesting is if we deprive the animal of sleep for 6 hours at the beginning of the light period, so we physically keep them awake, and then we allow them to freely behave for the remaining 18 hours, the 6 hours that are left in the light period plus the 12 hours of the dark period, we get massive rebounds in the amount of non-REM and REM sleep. So if I keep them awake for 6 hours, during the following 18 hours, they get twice as much non-REM sleep and about a third more REM sleep. So we anticipated that would happen if we simply disrupted their sleep, but it's not happening, and we don't know exactly why. Yeah, Richard?
It's very clear talk, thank you, very well presented. I had a question relating to, I'd like to speculate on why you think it is that these inflammatory, these cytokines inhibit the cell firing that you showed very nicely. That's number one. And correct me if I'm wrong, number two, I got the impression from looking at the time scale, and you had some slice work there. I can understand latencies with dialysis, it's hard to figure out what they are, but with the slices, normally responses are very quick, but they seem very long. So it suggests there's some interesting process going on that I just wondered if you had any insights from your reading, how it might be that these cytokines are inhibiting cell firing.
Yes. It's a great question, and I wish we had more detailed electrophysiologic parameters to support an answer. But we think they're GABA mediated, and we have some information on minis, which I get confused in my own mind. So we think there are some potential mechanisms there, but we haven't followed up with the EFIS studies. We haven't.
This is very interesting because there's some evidence from a different field with anesthetics that I know of, by Beverly Orser at the University of Toronto.
Right.
So when she exposes animals to a single dose of anesthetic, there is a time-dependent expression of certain GABA receptors.
Right.
It's interesting that you seem to suggest it's the same mechanism. This isn't the hippocampus, that it may be happening in these arousal centers as well. So there may be a commonality of what the and there's an increased expression of these receptors, which takes time.
That's
Very
good.
interesting.
One more question.
I mean, I know nothing about inflammation and sleep, but you know, the whole concept of inflammation comes up so many times in so many different other areas. And the question that always comes up, is it really a bad thing? Is it a good thing? And do I do any good by inhibiting inflammation? So what, for example, would there be a role by giving anti-inflammatories, and what would it be?
Yeah, so the shortest answer, which is the least satisfying, is it depends. So in terms of infection, especially bacterial infection, you're much better off to stay away from anti-inflammatories. In fact, it would be better if you didn't give your kid the aspirin during a fever after a bacterial infection. Why? Because fever is the #1 defense mechanism that the body has at its disposal. And when you damp the fever or alter that fever, you're actually aiding the pathogen. Now, when is fever problematic? If you're very, very young, if you're very, very old, if the fever is very, very high and very prolonged. But in a normal course, fever is a good thing, and you probably shouldn't touch it. Inflammation in the acute sense is generally a good thing. It's there for a reason. It's when it becomes chronic that it's problematic. And what is not well known is what the tipping point is under many of these circumstances that make this transition from what should be an acute response to a chronic pathology. And that's where it very clearly becomes bad. And I don't want to take any more of Mervin's time. But it's my pleasure to introduce the individual who traveled the furthest to get here today.
Pacific Heights, okay.
As you know, Dr. Mays is here at UCSF, and I'm looking forward very much to hearing his talk for us now.
But before I do, I just want to say that the previous speakers were so enthralling that there's a fair amount of sleep deprivation going on here now.
Yeah, exactly.
Maybe we can stand up and stretch for a second or two, just to
Yeah, we'll turn down the temperatures.
turn down the temperature, get some beverage and stretch yourselves, and then I'll put you to sleep.
Just cut off the brain and just try and
Oh, okay.